Hi, my name is Andrew Stein, and I'm a second-year internal medicine resident at the University of Florida, and I'll be presenting a pregnant female with newly diagnosed hypertrophic cardiomyopathy after critical adverse event requiring multidisciplinary management. I'd like to thank my listed colleagues, including my PI, Dr. Mustafa Ahmed, for their contributions. Hypertrophic cardiomyopathy, HCM, is the most common genetic cardiac disorder identified in approximately 0.2% of all deliveries. A major adverse event is sudden cardiac death, SCD, with an incidence of 1% per year, in addition to commonly identified atrial fibrillation and obstetric complications of preterm delivery and emergent C-section. We present a fascinating case of newly diagnosed HCM during routine blood pressure treatment requiring multidisciplinary management. A 25-year-old female G2P1001 at 23 weeks gestation with a history of hypertension presented to a local emergency department with chest pain and shortness of breath after being unable to fill her methyldopa. Family history was significant for SCD in her brother with autopsy-proven HCM. Her initial systolic blood pressure was 150 millimeters of mercury with elevated but downtrending troponins. A series of hydralazine IV pushes and extended-release diltiazem were administered for her hypertension, followed by an acute hypotensive episode which required fluid resuscitation and ephedrine. She simultaneously developed new onset atrial fibrillation. Bedside cardiac ultrasound was concerning for HCM with moderate to severe left ventricular outflow tract, or LVOT, obstruction, and she was transferred to a tertiary referral center for further evaluation by a multidisciplinary team, including heart failure, obstetrics, maternal fetal medicine, critical care, and anesthesiology. Upon transfer, her labs were significant for hemoglobin of 9.8, haptoglobin of 190, troponins greater than 27,000, and BNP 785. An esmolol drip was initiated for blood pressure control, and all vasodilatory agents were avoided, including hydralazine and general pain medications. Formal cardiac ultrasound showed ejection fraction 40 to 45%, asymmetric left ventricular hypertrophy with a 2.8 centimeter septum, without evidence of obstruction. Figure 2 is an apical 4-chamber echo view showing the increased septal thickness, with Figure 3 demonstrating similar on a parasternal long view. Her troponemia was suspected to be from tachycardia-induced subendocardial ischemia. For her atrial fibrillation, cardiology recommended amiodarone. However, maternal fetal medicine preferred cardioversion if necessary. She was transitioned to labetalol for blood pressure control, then metoprolol for improved rate control. For sedation, midazolam, a category D medication, was the preferred agent per anesthesiology, and propofol was to be avoided. The patient remained hospitalized given her high risk of SCD, awaiting a cesarean section at 33 to 34 weeks gestation, with discussion for AICD placement prior to discharge. HCM is defined by often asymmetric left ventricular hypertrophy with septal thickness greater than 1.5 centimeters, which decreases the LVOT gradient with potential for obstruction, placing patients at increased risk for atrial fibrillation and fatal SCD. Common treatments are included in the Venn diagram in Figure 4. In the 2020 AHA guidelines for HCM, as shown in Figure 5, outline risk factors to guide placement of AICD for SCD prevention. Separately, intrapartum treatment of hypertension and atrial fibrillation, again outlined in Figure 4, must account for increased blood volume, cardiac output, and systemic vascular resistance. Cardioversion is recommended for uncontrolled atrial fibrillation given the associated fetal toxicity of typical rhythm control agents. Combining these two physiological states creates a challenging scenario where the increased cardiac output of pregnancy worsens the HCM LVOT obstruction, decreasing LV size and leading to increased left atrial volumes, stretch, and risk for atrial fibrillation, which can be dangerous in HCM even at slow rates given the LVOT gradient. Similarly, vasodilatory medications decrease preload and worsen the LVOT gradient. Our case highlights a newly diagnosed case of HCM in a unique critical care setting following routine management of a common comorbidity in a pregnant patient. It demonstrates the importance of a thorough family history for SCD and early diagnosis of HCM to avoid preventable morbidity, even mortality, in complex physiologic states that may require multidisciplinary evaluation. Appropriate awareness of HCM and gestational pathophysiology, pharmaceutical mechanisms, and patient risk factors are essential to help guide optimal patient care in these challenging clinical scenarios. Thank you for listening.